Welcome back everybody, David here again with Med School Bootcamp. So in this video we're going to talk about the first of our types of incontinence, and that is overflow incontinence. Recall that urinary incontinence is essentially a leakage of bladder from the urine, and more importantly to note, it's involuntary. It's an involuntary release of urine or leakage from the bladder for a variety of different reasons, one of which is overflow incontinence. So the key thing I want to point out right off the bat here is that in overflow incontinence, we are not experiencing an urge to urinate. And this absence of an actual urge to urinate leads us into the pathophysiology, which is that this is most typically due to a decrease in detrusor contractility or bladder outlet obstruction. Recall from our previous video, we said that the detrusor muscle is the muscle that essentially outlines or surrounds our bladder, and contraction of this muscle is what actually allows or helps the process of squeezing urine through the bladder, through the urethra, and ultimately out of the body. And so if we have decreased contractility, we're losing that squeeze of the bladder, and thus it makes sense that we're likely to decrease the urine that's actually being excreted from the body. Now, you can also have a bladder outlet obstruction. And so if you turn your attention to our image down here, you can see this is an example of a patient with an enlarged prostate, oftentimes also called BPH. And this enlarged prostate can actually cause an obstruction, which can essentially narrow the lumen of the urethra, creating a more difficult pathway for urine to actually leave through the urethra. And so either of these things can cause overflow incontinence. And what happens here is that we get incomplete emptying of the bladder. So typically we would normally feel a full bladder, have a sense to urinate, we would go to the appropriate place and be able to empty our bladder. However, patients with overflow incontinence are not able to fully empty their bladder. And because they're not able to do so, they actually have an increased chance of developing bladder distension. So now, instead of a healthy urinary system where urine comes down through the ureters into the bladder and then leaves through the urethra, we've created a system where urine comes down through the ureters, builds up in the bladder, creates an extension in the bladder, stretching it out, and we were unable to actually get all of it out through the urethra. So now we've created this chronic state of distension, and because of this, patients begin to develop involuntary leakage, or because they're carrying around a distended bladder at all times, there might be various times throughout the day where they actually experience a leakage of urine, an involuntary leakage of urine. Let's think about it like we have a fishbowl. If we have a fishbowl that's only halfway filled with water, it's fairly easy to carry that around anywhere we go and not actually spill the water. However, now imagine that our fishbowl is actually filled to the brim with water, reminiscent of our bladder distension from the urinary buildup. Well, now if we walk around and we're carrying that fishbowl with us, what do you think is going to happen? It's more likely that water can actually splash out of the fishbowl. And this is a really good way to think about this overflow incontinence. If patients are constantly walking around with a distended bladder, they're more likely to experience that involuntary release of urine, which is in parallel to walking around with a fishbowl full of water and having that water be more likely to splash out of the bowl. Similarly, urine is more likely to exit out of the bladder if it is constantly distended. Now, let's consider some of the classic presentations that might be presented to you in a question stem. First of which is a weak or intermittent urinary stream. And this can make sense to us because we said one of the things that can cause this is actually an obstruction. An obstruction at the bladder is going to make it harder to get that stream going, and when that stream does begin, it's going to be a weaker stream. This is often referred to as a bladder outlet obstruction. The most common one they ask about is BPH. Additionally, we can also see urinary hesitancy, which is another way of saying that the patient has difficulty urinating. Two key points I want you to take away from this particular section is that the presentation classically only occurs when the bladder is actually full. And then the second key point is the one we already mentioned, is that overflow incontinence has an absence of an urge. This is super important because we're going to talk about in a future video one called urge incontinence, which, as you guessed it, presents with an actual urge to urinate. But here, patients don't feel an urge to go. It just happens because they chronically have a distended bladder. A key diagnostic step for these patients that's super high yield, and I put the high yield button by it, is that they have an increased post-void residual volume. So you can reason out from this what this is actually talking about. We say it's an increased post-void. So after a patient goes to the bathroom or after they void, you can essentially do a bladder scan. If that bladder scan shows an elevated level from what we would expect to see, that's indicative of an increased post-void residual volume. This is a classic presentation for overflow incontinence because we said, right, these patients are not able to excrete all of the urine that they would like to in their bladder, and that is the reason why they have a chronically distended bladder in the first place. So the post-void residual volume is essentially measuring how much urine is retained in the bladder after micturition or after actually trying to urinate, and this can be measured by using either an ultrasound or by using a catheter. We typically say that around 50 milliliters is normal. However, this is a bit of an approximation. This can alter depending on if the patient is male versus female. A lot of different things can alter this, but we kind of use that just for a general baseline for question taking purposes. I think that using approximately 50 is a good idea. However, in clinical practice, there's a lot more intricacies that can alter this level in terms of what we would consider normal. But for simplicity's sake, if you see a post-void residual volume of greater than 50 milliliters, you can think about some things that might cause that. And it could be things such as a obstruction obstruction, we talked about those types of things, or something that can cause detrusor muscle underactivity, and that the detrusor muscle is not contracting well or it's contracting less frequently, and this is causing more urinary retention for the patient. Next, I want to look at management options for this. So for these patients, you can do intermittent catheterization. And the reason is because we're trying to decrease the amount of urine in the bladder. So if we have this scenario with this full distended bladder, if we insert a catheter in through the urethra, that can actually help us drain urine from the bladder into an external reservoir, and that's obviously going to decrease the overall distension in the patient. And can you think about why we might use intermittent catheterization versus an indwelling catheter or one that stays in for a longer period of time? That's right. If you think about it from a clinical perspective, this actually comes with a decreased risk of urinary tract infections. Some other things we can do to help out these patients include medical management, such as alpha-1 blockers. And you remember, what is the mechanism of action of an alpha blocker? That's right, it inhibits the alpha-1 receptors specifically at the bladder neck and the prostatic urethra. By doing this, we actually get relaxation of the smooth muscle, which creates more space for urine to actually pass through. This is ultimately going to decrease urinary flow resistance and allow for symptom improvement. Additionally, you can also use another medication called bethanechol. And do you remember the mechanism of bethanechol? That's right. It's a muscarinic agonist that specifically acts at the M3 receptor on the bladder that can actually cause contraction of the detrusor muscle. And greater contraction of the detrusor muscle is going to increase our bladder emptying and thus improve the patient's symptoms. And finally, we can also consider things such as surgery. We said a classic presentation might include a patient with BPH, and so a prostate resection might help with relieving that obstruction if that is indeed the cause. And so that's why it's really important to keep in mind this final portion about our associations. Because if we're talking about BPH, right, we might be talking about an obstruction, surgery might be indicated. But there are some other key causes, such as neurologic causes like diabetes, multiple sclerosis, or spinal cord injuries that can actually cause more of an autonomic neuropathy or more of a nerve problem, right? So if we have a problem with our nerves, we might be decreasing our signals to the bladder and thus decreasing the ability of the bladder to actually contract. And the same thing goes for a spinal cord injury. If we have a dysregulation in our ability to control our parasympathetic versus our sympathetic outflow, we might decrease our ability to control our organs such as our bladder. And we know from the last video that urinary voiding is primarily regulated by the parasympathetic nervous system. So anything that disrupts the pathway of sending signals is going to lead to urinary retention. So just to summarize for this video and give you kind of a classic presentation, it's probably going to present in one of two ways. They're either going to talk about a patient who has clear signs of BPH, such as an elderly man who has difficulty urinating or is frequently trying to urinate, or they might present it to you in more of a neurologic patient, right? Somebody with a spinal cord injury, somebody with a stroke, multiple sclerosis, some way in which these patients are lacking the ability to pass along neurological signals for a variety of different reasons. This is more likely to present as the decreased detrusor muscle contractility versus the bladder outlet obstruction of BPH. Signs and symptoms are going to be relatively similar between these patients, but the key diagnostic step that they're very likely to give you in a question stem, because they really want you to understand this association, is the post-void residual volume. They'll talk about doing a catheterization or an ultrasound, and the post-void residual volume, that is the volume after the patient has gone to the bathroom and urinated, is, let's say, 200. Well, we can think, okay, 200 is well above our normal range of approximately 50 or so, give or take. And so this patient, although they recently went to the bathroom, has significant retention of urine in their bladder. This is going to lead to incomplete emptying, bladder distension, and ultimately involuntary leakage, which is what incontinence is, of urine from the body. Treatments are really going to be aimed at symptom management. We can do medical interventions, we can do catheterization, and we can even do surgical intervention for the right patient. So it's reasonable to assume that a patient who's dealing with more of a neurologic presentation is more likely to benefit from catheterization or medical management versus surgical intervention. A patient who's dealing more with a post-bladder obstruction, if they're consistent with BPH, is potentially going to benefit from surgery. So those are kind of the two classic ways, the two kind of classic patient presentations that they will ask about for overflow incontinence.